All right, here's a marathon series of 4 lectures from me. So we're going to talk about temporal point and lateral hump reconstruction. You've seen the slide before. You really know the subregions, so we're going to talk about dividing those into smaller units today. And remember the concept of the head like a box. The temporal point, temple, and lateral hump reside on the the vertical scalp, on the side of the head. So if we think of it like a spectrum, a lot of things what I do are not all or none, they're all spectrum related. I think about the very bald person needing a lateral hump reconstruction. To me, this is very advanced. It's not just advanced in terms of design and reconstruction, but thinking about if this guy's that advanced, are you going to have a problem because there's going to be ongoing progression, you're going to have issues. Why do I put temporal point for the least bald? Because you can have a very bald guy with really a need for a temporal point. And the real reason is that, and you're going to hear this in my lecture, is supply and demand, wasting so much graft on this area, not only the fact that it's very complex in design, and then you get what's called a front heavy result where all that sits is in the front. So I don't do temporal point unless I've got great donor capacity and prediction for the future. And you shouldn't do it because it's too difficult to do. I will be running a 3-hour temporal point reconstruction and crown this afternoon, but please understand, I'd rather teach you upper temple and then crown, which is moderately advanced, but crown is moderately advanced simply because of prediction of future problems more than anything else. So this is that spectrum in another context of just looking at this thinking, geographically where we're going. The farther you go forward into that temple, the more difficult advance and the more risk that you have. So this lecture is going to be divided into macro and micro, meaning how do you design these lines and then how do you make the sites, okay? So the first thing we're going to talk about is temporal point reconstruction. I emphasize again, this is a very advanced procedure. It is an advanced surgeon and an advanced team, because if you do great sites, which you will not do, I'm sorry, and your team will jack it up, because when they place into these very low sites, it's not going to look right. So I think it's a person that has minimal hair loss. We said, what are you talking about? It should be someone that, no, it's because I'm worried that I'm going to use all these grafts to sit this head way up in the front, and they're going to be bald back here, and it's going to look like a hair system gone bad. It looks weird. It actually is great for someone with a hair system where they've got such great loss that this is the only area that looks artificial. I'll build the temporal point knowing that they're going to wear their hair system in place. That's another way that you can do it. But great donor capacity that overcomes a lot of evil, and other priorities all met. Because for me, I rather do the front, the crown, everything but the temporal point. But the benefit is that it's awesome. It looks great. It's a balanced result, and it just looks like a very strong masculine facial frame. So how do you design it? A concept, and I'll be honest with you, to me, practically speaking, this is a textbook answer. I think this is a little too aggressive, and I'll show it to you in lab, but essentially what it is, you draw a line through the mid-pupil, through the nose, that's one line, and then through the earlobe, you go to the point that you designed on your hairline, and then you draw that. That becomes a self-correcting temporal point. I'll be very honest with you. This is actually, when I've done this in practice, it looks more aggressive than it is, but it's just a blueprint to start. You need to go once you've drawn this line, which I think is a little bit too aggressive, go behind it, all right? But you need to study natural temporal points. You got to see what's out there. The funny thing is, I always just draw my temporal point by hand, and then I said, I'm going to use this thing and draw it in with this technique. Oh my God, it doesn't look right. So, this is in every textbook, including mine, as a start point, okay? Recipient sites, they go super insanely flat. I use bent needles to create this. I have traction. I'll show you this. I'm very, very careful. And the trick is in the temporal point, which is this thing, it goes back. Why does it go back? Because if you make them going down, they're going to hang over the naked skin, and it's going to look bizarro. And if they're sticking out like this, okay, forget the surprise stuff that Vance talks about. This is a real big surprise when you walk into a room with one of these and you can't fix it. So I use bent needles for this. I don't use solid cord needles, and I use very small grafts, one and then for the frontal zone, and then 2 hairs when I go farther back in that area. I don't use 3 hair grafts in the zone. It looks weird. This is an example I showed you yesterday. So the right side for a right-handed surgeon is pretty easy. The left side is more difficult to get low sights. So I used to bend over and do this. I now sit and press upwards into the area. You have to maintain sharp needles because the skin gives, so there's two things. You have to maintain sharp needles or it's going to dull and you're not going to be able to place into those sites, and you must have counter traction. I now have a dedicated assistant that holds counter traction on my temporal points until I'm done, then she leaves and then I continue the procedure. So that's counter traction with an assistant, I think is mandatory, or they've got these clamp devices that hold it back. I have used those. I just like a person holding it. So upper temple design, this is really what I would have you guys do. This is the limit of where I want you to walk home with. It's good to know all the knowledge, but it's good to avoid problems. So this is actually really good. The more I teach in lab, the more I realize what I'm not teaching. So we heard all the hairline design issues. So yes, I saw a gentleman, that, you know who you are, that drew a line that fit all of the rules except one. He had the thing didn't tilt down, it tilted right. He was at the shingle point, that was correct. He drew his temple line that was actually relatively okay, but his hairline sat 8 miles ahead of his temple. We didn't talk about that. So the problem, if you do that, I call it the lid effect, which is the next slide, which is the idea that if you have a hairline way out here and the temple back here, it looks like a hair system. It doesn't look balanced. So you want those to, you gotta think of this as sort of naturally unzipping. Now, I'll be honest with you, when we do hair surgery, we've oftentimes got to place the hairline a little bit anterior to the temple. It's just the nature of supply and demand issues. But you don't want that hairline jutting out 5 miles in front of the temple. And then if you see that, what do you do to fix it? Move your hairline back. Don't move your temple forward, especially for the beginner. You're going to have problems. And that's the idea, is when you look at this, you don't want on the right, the non-grayed out area, having that hairline sit way in front of the temple. It just looks weird. This is a reiteration of a point that is, we talked about yesterday, the concept, to reiterate, how do you know when to design an upper temple? This is a question I've had for 14 years and it's finally solved in the new book that's coming out, that just came out actually, that you can draw a line 2 centimeters anterior to the EAC, external auditory canal, you can draw that line in of that lateral canthus. When I taught hairline, the biggest failure I saw is not getting the lateral canthal position right. Use that pencil to go up. I do it. I'm over 20 years in practice. I still use an eyebrow pencil to just make sure that I'm in alignment because it's a curvilinear space. It's very hard. When you see the junction of those 2 points, if your hairline sits anterior to that, when you're designing it, you probably don't need an upper temple. If your temporal point, if your temple sits behind it, you probably need a little bit of upper temple to match the hairline. And we can go over that in lab today if there's any questions to show you that. So the angles and directions, they're somewhat low in the upper temple. Lower the better. You can't go too low, but it's not as vital when compared to the lower temple and the temporal area in terms of the lowness of it. I'm using 1 or 2 hair grafts, the front 1 to 2 rows are 1s and then 2s, no 3s in this area, and I'm talking about 3 hair follicular units, if that abbreviation did make sense to you. Just as an example, I mentioned to you that there are no abrupt transitions, and you can see I don't fan out that central hairline. They go pretty far forward and then they just slightly curve onto the side. So this is something that I came up with for the new book that I think it's hopefully a novel way of simplifying a lateral hump design. This is why when the question was asked yesterday, I said, let's hold it off because I have a lecture today. I don't want to mix simple, nor would 3 to 5 hair transplants or 3 to 6s with how to do a 7, because to fix a Norwood 7 is a very advanced concept. So the idea is, where is this lateral hump? Remember, it looks like an upside down bowl. It's on the side of the head. When that starts to recede, you have a Norwood 7. That's the definition of a 7. Now, the gentleman I'm going to show you is way too advanced to do actually a transplant. He just was a father of a friend of mine that came in so I could photograph him for the book. So I would never transplant him. But I think it's just a good education. So how do we design this? Remember how we started? We started with the anterior point. Don't do that with these advanced ones because you're gonna, by nature, not know how far forward or back to go. You won't make it conservative enough. You're gonna make it too far forward. So we need to balance it on the hump. What does that mean? So I start with the hump. So this is the concept, is that I start with the hump. What does that mean? So along that axis of that lateral canthal line, I go to the side of the patient and I look at where the apex of that hump is. Okay, the apex of the hump is this. In case, I hate using laser pointers, but let's see if this thing works. No. There we go. This is the apex of the hump right here, okay? That's the apex of the hump. So I go from the apex of the hump and go straight north. That tells me the apex of what I'm going to design. I do that on the other side, and then I sort of check if I'm midline. Remember I told you, cross-check. You guys, when you're doing hairlines, tilt the head down and look if you're midline. You guys are not doing that and then I take a ruler. I don't do this anymore, but if you need to take a ruler, just measure if your humps are not off, because I will tell you as you start, you're going to have your humps off. You're going to have everything off. Your frontal temporal corners are off. So I start with that, and again, I would not design this. This is too aggressive. You see the loss, but it's point of an intellectual understanding. So then I finish the hump. After I've designed the humps, then I create this central island in that area. Then I know I can balance it either exactly evenly on that area or slightly in front. Now, I'll be honest with you, a natural northward pattern does not have a hairline that sits anterior to this design. This is not even exactly a natural northward pattern, but it's as closest thing I can do with an advanced hair loss. This is why in general you don't want to be transplanting these, but you want to do it in a very careful way that the public cannot see this. So from all views, you're seeing how I've basically centered on that. Now I would soften those angles so it's not so an abrupt transition point, but this is the concept of balancing it. So this is the new concept I've delivered in the book, which is to balance it. So let me show you. If what's in green is a very normal or regular old transplant, I transplant the front to the back, where if you just transplant the front half of that green and not the back half, for example, you're going to have a front heavy result. What is a front heavy result? What is shown in blue. The blue means I've designed the front and not the back and have this aggressive hairline anterior to the loss. It doesn't look right. You're not going to have the eye to understand this for 5 years, okay, maybe 7 to 10. But I want you to develop the idea of balancing the front to the back and not have it, especially with the more advanced losses. So what's in red is you can see I'm slightly anterior to that vertical line, but not too much. You don't want to create hairlines way in the front of a lateral hump recession. It looks weird, okay? So that's the balance concept on that central line pivoted on the apex of the lateral hump. So lateral hump recipient sites, they're going to look like they're cascading forward. So they go forward and then down. They start falling down. And as you go all the way to the back, they go vertically downwards. So the directions and graphs, I use more 3s on the top and then 2s farther down. Now, be honest with you, that's the opposite of what exists in nature, because as you recede, you have a wave of thinner hairs on the top, not the opposite. So this is a very dangerous way to transplant if you don't know what you're doing. If you heard this and say, Sam uses more 3s up high, you need to put enough density below it so that it transitions down. I'm using the 3s to cascade down to cover my 2s, using the cascade principle. But if you don't do this right, you're going to have these dense grafts sitting up here and these weak 2s, and it's going to look not like a normal hair loss. So I would tell you to reverse it and use more 2s up high, maybe 3s lower down, because you're going to mess this up. But I'm telling you how I do it and how you can aspire to do it. But early on, you don't want to do it. If that makes no sense to you, let's talk afterwards, okay? Because I know this stuff is very confusing. So these are just an example of my design, and then some quick results. This is a frontal temporal point design. This is another temporal point design, another temporal point design, another temporal point design. So this is 10 years actually after a temporal point design. This is a lateral hump build, so he stabilized well. He was compliant with medical therapy, so that's great. So sometimes medical therapy is great. I went back, the reason I saw him 10 years later, I went back and added more grafts. He is great. He's in his mid-50s. He's holding well. And so, but listen, does that mean I'm a good predictor of future hair loss? No. It means I'm probably better than you because I've been doing this 20 years and I'm incredibly conservative in whom I pick. I can take a day and just turn every single patient away for surgery. It's easier for me at 20 years in practice, but I'll tell you, it's never easy to say, no, I don't want it, for 2 reasons. I'm losing money, and I'm having a patient that is depressed. They can't do it, but I'll tell you, it's the right thing. So understand the spectrum of temporal point to lateral hump. Avoid temporal point and lateral hump for beginners. So you're doing temporal points to start, don't do it, you're gonna have problems. Lateral hump seems easy, and it is technically easier, but I will tell you, it's not the fact that you can't make those sites. So if you get excited, if I show you how to make a lateral hump in the lab, you go, I can do this. And maybe your staff can place into it. The judgment of dealing with Norwood 7s is very difficult. Unless you're dealing with a white-haired 70-year-old where you're not worried too much about aesthetic goals and he's pretty happy with some hairs there, great. But if you're doing a Norwood 7 and a 35-year-old, that guy is going to have a problem in 5 years that you can't exit on, okay? Just like the story I told you of the Norwood 6 25-year-old that decided to go overseas. My God, he's going to be in a disaster land in 10 years, and I won't be able to fix it. And he barely can handle things because he has sexual side effects from finasteride. It's going to be difficult. So understand when to perform the upper temple based on those two intersected lines. Again, I can go over that with you in lab. Okay, that's the first lecture of 4. Hang on, put your seatbelts on.